So we have heard a great deal, and we are getting many tweets and many messages from many people out there. And I would like to share just one with you in terms of what people are saying. And I know you're going to share a lot more, Anthony. But since this continues to be viral, it's important to engage you also in our conversation, especially those of you from the South and many other places in the country. So someone says, the strategy speaks to me about building on promising practices on innovation, strengthening meaningful private-public partnerships and establishing mechanisms to accelerate them, reducing redundancies and aligning all these efforts among all these agencies and the community. So we welcome your comments. And now, Anthony, what can we do to tangibly change the way that we do this business in order to help our communities?
Our first panel, the next panel that we have is going to describe something that we at GMHT try to address every single day, and that's, matches what we just heard, which is addressing the holistic needs of our communities. And before I sort of pass it off to our moderator, I do want to remind everybody that we are, I'm doing a little housekeeping, we are a little behind. Some people do have some flights to catch, et cetera, so we just wanted to remind everybody of the time and sort of just be aware, but obviously with such powerful testimony that we're hearing this afternoon, really incredible time together. So with that, I'll pass it on to our moderator of this panel, Atlanta's own Dázon Diallo.
Thank you. All right, so this must be the Grand Slam panel. I mean, we've got to bring it home, and we've got to do it pretty fast. So thank you all so much for sticking around, and just one more time for the previous panel. Yo, that was like 6 mics all dropping at once. I mean, seriously. So very quickly, and just in the interest, you all sent some really fabulous bios, but y'all got the Google these days, so if you really need to know more about any of these 3 individuals, please visit their individual websites. If you're Facebook friends, ask them yourselves, tell me about your story, but we're not gonna go into all of their bios. We'll work with their titles for right now, if that's okay with y'all.
That's fine.
Okay, because we have 3 people who all have to make flights tonight, and this afternoon, actually. I want to say thank you again. Thank you for the introduction. Thank you for an incredible day. And also thank you for actually exceeding expectations with an incredible National HIV/AIDS Strategy update. I mean that. Y'all can applaud for that, because I don't know how many of y'all were lowballing it. I know I was, just because, we didn't know what was in it, so we're like, okay, it must not be a lie. And it actually is, so I am happy to say I was wrong in my expectations today, quite frankly. I'm learning to tamper my uber optimism. So I also want to welcome you all as a person who's not only an Atlantan, but this is my neighborhood. I went to school across the street. I am an adjunct faculty here. Our main office is down the road, and I live 7 minutes from here without traffic. And so I'm really excited to have y'all not only in my town, but in my hood. So welcome to the West End. And I would say this because I probably won't get any more time, because we're going to give it really to the panels for the rest of this conversation. But I do want to acknowledge really the power in what's been presented today in the update of the National HIV/AIDS Strategy, and how it's been acknowledged that it's not just in the strategy, it's not just in the plan, but it also is somewhat a plan of action for us to take up. And being here in Fulton County, being in metropolitan Atlanta, being in the state of Georgia, which from where I sit is quickly becoming one of the newest epicenters of the HIV epidemic in the South, in real and incredulous ways that are absolutely unacceptable. It's great to have a new tool to take to our local leadership, and to be a new part of our leadership, to say we actually have a national pathway that can help direct us more locally and more successfully going forward. I also had a couple of comments, because Cornelius had a really few great questions. And I would say that reminding us that 5 years ago, in 2010, there were a bunch of us, some of us in the room who know the meaning of the red scarf, with 30 for 30, we're really fighting hard just for women's inclusion in really meaningful and intentional ways in the national HIV/AIDS strategy, and have been on the forefront of that fight for the last 5 years. And I want to acknowledge that Black women got a metric. Hey. So I want to thank the team, especially the indicator team, for that. At the same time, however, because I wouldn't be me if I sounded like I was totally happy. However, I want to acknowledge that there was a lot of research, there was a lot of information gathering and analysis and synthesis that went into being able to deliver to us what these indicators and the action now need to look like. But in any good talk of your study and of your work, in addition to giving us the problem and giving us the methodology and giving us the results, you also usually give us the limitations. And I think it's going to be important for us to continue to be open and acknowledging some of those limitations. And what do I mean by that? I'll just give you a clear example. If I read it wrong, Andrew, we can have a conversation because we talk anyway. But for example, indicator number 9, where we actually do give some indications of the reduction of incidence in key populations, I found it odd that we have gay and bisexual men, we have young men, we have the southern population of people living with HIV, and then we have Black females. And it's been a long time since we've acknowledged that we don't talk about us as females. I'm usually listening to hip-hoppers and people on the street call me a female.
That's right.
So what female does is it privileges biology over gender.
That's right.
And I know because of what even Shannon just talked about a few minutes ago, we may not have all the data we need to have that indicator for transgender women yet, but I'm clear that when we don't have an indicator for transgender women, and then we have to identify cis women as females in order to acknowledge that we still have a lot of work to do.
That's right.
That's all. So let's acknowledge our limitations and continue to work together on making this strategy real. And so that brings me to my people right here on this panel. So first we're going to have just a couple of minutes. I know we said 3 to 5 before, but now it's just a couple of minutes. If you would just give your brief opening statement, even if it's your own reflection of today and how the work, because you're representing what we're calling the private sector. We're talking about the local community health providers, we're talking about the university and research partners, and we're talking about the funders and the strategists that work at the national level. As a part of this conversation, we had community, we had the public sector, we had the federal response. This is also the folks where the rubber hits the road. And so if you would, Dr. June Gipson, who is the President and Chief Executive Officer of My Brother's Keeper, if you are ever, for example, in having the opportunity to visit My Brother's Keeper, you awesomely must. And if you would, June, just give us a couple of comments, and then we'll follow with Michael Kolber from the University of Miami and Monique Tula from AIDS United.
Well, thank you so much, and thank everyone for having us. I'm really enjoying this. This has been a very passionate meeting. I've been to meetings before when it's a lot of talk, but this one has been very impactful, and everyone's had the opportunity to really say what they mean and to actually get it out. And for me, Mississippi, and I'm looking at this, and the title is Getting There, and I'm thinking how fitting for Mississippi. Believe it or not, we are actually getting there. My Brother's Keeper is a nonprofit organization, but we also have Open Arms Healthcare Center, which is the first LGBT clinic in the state of Mississippi. And we are thriving. And as we continue our talks, I want to tell you more about what we're doing and how we're doing it, and also just really get you to really know and to feel that Mississippi is actually getting there.
So I'm on the stage to talk about comprehensive care, but before we get to any of that, I want to say a good segue into that is what I saw before in terms of our panel. I think they did a remarkably good job and teach us a lot about how healthcare needs to be moving forward, not only in HIV, but also for those who are not HIV positive and poor. I think we have advocates like this. These are people who stand up for those who can't stand up for themselves. And I think that's critically important, and I don't see that right now for the poor. And I come from a state where Medicaid isn't expanded, and this is a big problem. But this is the beginning of the conversation, the threads that build a comprehensive care program, the people who can communicate with the people who need the care and bring them into the care system. And I'll talk more about it, I hope.
Yeah, we'll get you there. Monique.
Thanks, Dázon. I'm happy to be here. Thank you, everyone, for doing all that you did to get us here, and especially the folks who stayed with us. Okay, so we're here for one reason, right? And that's to hear the release of the updated goals. So we got to make sure we remember what they are, right? So widespread testing and linkage to comprehensive care, broad support for treatment adherence, universal viral suppression, and full access to PrEP, full access to PrEP, right? But none of that can be accomplished if we don't have a strong infrastructure that supports really innovative collaboration between the public, private, and nonprofit sectors, right? Because we all really need to work together to meet some of the complex needs that the panel previous to us just talked about so well. And we believe at our organization, AIDS United, that healthy organizations make for healthy communities. So whether it's through our grant making or public policy and advocacy or capacity building, we're committed to ensuring that people have all of the things that they need to do all of the things that are so well articulated in the National HIV/AIDS strategy.
Thank you so much, Monique. You all can give her a hand as well, please. Thank you. And actually, I'm going to start with you, Monique, and I have about, maybe at the max with the time that we have, maybe 2 or 3 questions each. So I'm going to start with you, Monique. And some of this is coming from our Twitterverse too, but also some of that we've thought of ahead of time. I know we've got Twitterverse people up here, but that's okay. We can still read it for you. That'll be fine. But Monique, let me start with just the fact that the update itself calls for these innovative models of service to reach some of these key populations that we just talked about. And from where you sit, especially with the social innovation program that's been running at AIDS United for the last several years, can you just talk about, in terms of some of that sector transformational work, how you see that sector transformational work addressing those populations? And then there was a follow-up for that.
Okay, great. So, we're a really creative bunch of people, and we figured out how to make great things. When I say we, I'm talking about our field. I'm talking about the HIV sector. And we figured out how to make great things happen based on small but elegant ideas, right? And we started 34 years ago with nothing, and look at what we've built and how far we've come. So a few examples that I can think of include the creation of a statewide health home model in Wisconsin based on a merger between 2 what we used to call AIDS service organizations. We're moving on, right? And then in Alabama, there's a small but mighty organization that implemented telemedicine, right? Which has completely revolutionized the way people living with HIV in rural settings receive their health care. And then also, more recently in DC, we haven't talked a lot about harm reduction today, so I want to make sure I get it in. But there's a small harm reduction organization in DC that has been serving sex workers and drug users just forever, right? And in a few days, they're going to be opening a brand new center that brings together harm reduction, behavioral health, and medicine in a way that hasn't happened before for that community. So those are just a few examples, Dázon. I'm going to try to keep it quick. And I also just want to say, I got a flight to catch.
Yes.
And so if y'all see me get up and go, that's where I'm going, because Sister got to go home. This has been wonderful, but Sister got to go home.
Well, let me throw in my next question for you, so just in case you do have to up and run. And that is, especially with the implementation of the Patient Protection and Affordable Care Act, I love that people always leave out the patient protection part, but that's actually where some of the rights-based work and the implementation of the ACA goes. So with the implementation of the Patient Protection and the Affordable Care Act, recognizing that it's not happening universally everywhere yet, y'all are sitting in a non-Medicaid expanded state. We know that there's been infusions of funds into community health centers. There's been infusions of funds into public health services. And there's been challenges, especially at the community-based level, of maintaining survival, of being able to identify relevance, of being able to strategically plan going forward in a time of uncertainty with all of this really helpful and necessary health transformation going on, but with the fear of being left behind or left out. And so we continually hear from our strategists and our leaders in the planning community that community-based organizations in particular, but organizations are really looking at three options essentially, is that you merge, you grow, or you go. And I think that AIDS United has taken a different perspective on that, and others, organizations as well. But can you talk a little bit about that in terms of what are the challenges, but also what are some of the opportunities with the update and with this notion of community-based survival?
Right, so that's not a simple question. Because for the past few years, there's been this growing uncertainty about grant-based funding, right? And all of the programs that we've been talking about, the innovation that we've talked about, requires sustainable funding. And so this has sort of driven community-based organizations that are providing HIV services to develop aggressive strategies that really help them diversify their revenue, and then also heighten their ability to maximize the impact of every single dollar that they get, because every dollar is precious. So then the question becomes, how do our organizations really respond to the changing healthcare landscape? And so that's exactly what the AIDS United Sector Transformation Initiative tries to do, is it tries to help organizations answer those questions. And so it could mean, for one organization, technical assistance in the form of support in the form of technical assistance around the healthcare marketplace, right? Or for other organizations, it could be integration of new innovative service models. Or for other organizations, it could be merging, with other groups. But the fact is clear, that HIV care and treatment services, the field is evolving faster than ever. And, if we're really going to get to zero, then we've got a lot of hard work ahead of us. And I think that very quickly, the first change is really in mindset. So, it's a new day where we all have to embrace accountability and outcomes. And so it's not enough anymore this is my people telling me, never mind, this is my people texting me on stage. The time is really past where we're simply entering data into CareAware and letting somebody else analyze it, but we ourselves don't know what the data is or how important it is and what it tells us about the people that we serve, or what our place is, what our role as HIV community-based organizations, what our role is in those communities. So we have to be able to talk about that data, and we have to make it relevant, and we have to be able to sell what we do to other groups, right, upon whom we depend on, that the people that we serve depend on, because I think that what we bring is a very unique value that adds a lot of value to some of the healthcare organizations that really don't have sort of the histories with the groups that we've spent so much time providing services to.
So is it still that merge, grow, or go, or is it merge, grow, go, and then some, and then determine what the innovation in the then some needs to look like?
It's creating space to think strategically, creating space to think critically, and then whatever the decision is that's right for your organization is to do it in a way that's responsible and responsive. And respectful. Thank you, Douglas.
Thank you. Thank you, Douglas. So thank you, Monique. And if I may, Michael, the update speaks to the need for comprehensive, integrated services and care that respond to the complex lives that were so brilliantly delineated by the previous panel in terms of the complex lives of the patients that we serve. And you actually lead that kind of work at the University of Miami in the School of Medicine. Tell us how you've done that in a busy urban area with all of these different players at hand.
Right, and that gets to almost the question that you were addressing, is that you have to believe that HIV care can't be owned by just any one person or group. You have to believe that you work as a group in a large community, and that nobody can serve all the purposes. And that when you believe that and you make alliances with other groups that can do things, you can keep them going and you can keep yourself going. Universities, for example, are not doing as well as they could because a lot of the funding is going outside. But you build these relationships to provide care in areas. So you, for example, at the University of Miami, we've been building a patient-centered medical home for many, many years. Everybody's now building a patient-centered medical home. I'm not saying we were the leaders, but HIV care has always been a leader. But what we have done is made a lot of relationships in the community so that if a patient needs to be seen at some of these facilities and they have the capacity, we would rather patients be seen locally than having to travel. And so we don't need ownership of all the patients. If they have good case management, if they have dental, we would rather they go there. So what we try to do is build a relationship throughout the community. And I talked about the threads of the fabric. I mean, by yourself, you're just not going to make it. There'll be times when you don't have funding, but you don't need to have ownership of everything. And when you work with a lot of different groups, all of a sudden those needs sort of become diminished and you can survive as part of the whole. I think that research allows us, especially with the way NIH is moving and HRSA, to layer on there a lot of opportunity to work with various groups. And we're building those relationships, especially with various CBOs, federally qualified health centers, on top of the care that we give. So it builds structure into it. And add on to that, we've added the AIDS Education and Training Center, which allows us to not only educate providers in different facilities with which we work, to strengthen those relationships, and now it's moving towards practice transformation, which we've already done. So at the University of Miami and Jackson Memorial Hospital, our goal is to not own everything, but to become a good community partner and to build the community system more than just our system alone.
Absolutely. And actually that's going to follow, thank you, Michael, that's going to follow for you, June, because that's what you described, Michael, is the unique capacities and advantages of the university itself. Even in the midst of the challenges, there are some unique places that only the university could do some of this work. But June, similar to that, you have built an extremely robust interagency system with medical, community-based, hospital, health department partners, as well as a rich engagement of the community. There's also this amazing quilting, if you will, because you're from Mississippi, or you're in Mississippi, the quilting of the healthcare delivery with the social, with the behavioral, as well as with the cultural work that happens on the ground in a community-based setting. So what are some of the best practices and lessons learned, and because I heard you give a brilliant talk in Memphis about this recently, about how you've been able to actually cobble all of that together and do it so successfully in what I would consider a less than favorable environment here in the southern region?
Yes, I will agree. Less than favorable.
Yeah.
It actually, the last time we were here, I know I talked about Open Arms, I talked about MBK, and all the great work that we were doing. And within the next couple of months, a fabulous grant opportunity came out from the United States Department of Health and Human Services. And when I saw it, I immediately said, did they hear me? Did someone actually listen? Mm-hmm. All of a sudden, there was this surge of partnerships, forced partnerships. You can't get this without this. Now, I felt that my brother's keeper and Open Arms Health Center were fabulous together. But this application forced me to get other partners. Mm-hmm. And I was absolutely amazed at how we have grown from these partners. The clinic went from first year 400 appointments. The next year, we had 1,100 appointments. Within the past 6 months, we've had 1,600 appointments. And this is all from the partnerships. So I guess the biggest lesson I've learned from all of this is that you cannot operate in silos. You have to have partnerships. And with those partnerships, you're able to layer your services. You're able to offer more because you're not trying to do it all. I don't do housing. I'm not going to start doing housing. I want to partner with someone who does housing, does it very well. I will mess housing up, and I know it. And I'm honest about it. I have no clue how it works. But that's the thing of partnering, and I'll say it over and over again. Partnerships work. It is the wave of the future. If CBOs want to make this, if they want to actually survive in this, you're going to have to partner with someone and go to the table with something, not asking for something all the time. Right. Say what you have. What do you have to give to this process? And from there, we have exploded. We've opened a new office on the coast, MBK South, and it's all based on partnerships. And when I was listening to the Surgeon General talk about medical and biomedical and public health, I just immediately want to jump up and say, me, we've done it. We have a partnership with the University of Southern Mississippi where we have an internship program where we're merging public health into biomedical research students' curriculum. We have it for 10 weeks out of the summer. They pay $4,500 to work in public health, to do what we do in public health. So this is chemistry, biology. People who want to be doctors are getting public health before medical school. They're getting it now. That partnership has allowed us to be able to spread the public health word, the HIV prevention word, STD prevention. It has become it's amazing. And so if I can give anyone any advice about moving forward and how to actually take advantage of where we are and what we're doing, play well with others. It'll make a difference.
That's excellent. So, and we're going to get to a couple of Twitter questions also, but this is one that I had thought of really because we have a 5-year window in terms of the strategy to look at. And there's some really aspirational things, obviously, that in terms of the issues around human rights and the social justice components of ending HIV and all of that, which we can continue to work on, but within the next 5 years, what can we actually see happen? And so I'm just curious about as you hear the strategy now in its newest iteration, that in terms of the particular part of the private sector that you represent, what are some of those components or those indicators or elements that you think you're going to be able to address quickly? Like these are things that we're working on or ready to move on that have somewhat already been identified in the strategy. And which components do you think are going to require much more time and scale up or capacity strengthening? We can take it down the line.
Well, I'll start. I thought about that when you said it. The first thing I think is virus suppression. I was amazed to see the numbers. And when I think about virus suppression, that is, of all the indicators, that's the one indicator that really depends on wraparound services. Motivation, all that's fine, but if you don't have food, if you don't have housing, if you don't have transportation, it's all wraparound. It's not the primary piece, it's what you get in support services. It's one thing to get there, it's another thing to stay there. So in the essence of the spirit of the strategy, don't leave those individuals out. I think that last page says that everyone has to work together. To maintain that virus suppression, we have to continue to wrap around services. I think we can accomplish that. The one I think is going to be a little harder, and it may be because I'm from Mississippi, is the youth piece. Trying to figure out why we're not doing well there. Well, for me in particular, once they come to us at 18, because most grants start at 18, sexual behaviors have already been set. They've been having sex was at 14 and 15. It's hard to say 18, you're going to change that now. And so because we don't have adequate education, and then we have family planning monies that they want to cut, because all these things are in transition, and you need those things to be beefed up to put into school so that we can set the behavior early. So when they come to us, they're not already in practice mode. We need to be there once they start to practice. It's like crossing the street. You don't let your baby cross the street by herself. You're there with her. So if she does it on her own, she'll figure out a way to do it. It may be incorrect. So we need to start earlier with our youth if we want to impact those factors, because at 18, it's too late.
Thank you. Michael?
So when you look at the care cascade, the biggest problem is retention and care. The biggest jump from linkage is to retention and care. And that's the challenge that we face in our clinics. And I think our ability to coordinate care for the population with which we work, which is majority is indigent, is a big challenge. People leave the hospital, and that's when a lot of problems start. People have the same problems that you just mentioned. They have housing problems, they have transportation problems, they have all these social issues, they have trauma problems. Most of our patients live in areas where gunshots are the typical thing for them. And it's a major problem. How do we deal with all those problems will be the issue. And all those, in my mind, play a role in this keeping people in care before I see them in the hospital, which is unfortunately too frequent.
And thank you, Michael. And Monique?
So, I don't know, I think that we have to overcome some policies, frankly, that get in the way of people's health, lifting the federal ban on syringe exchange, for one. And, we haven't talked a lot about that today. And the previous panel mentioned the criminalization of HIV, and y'all, why we are not more outraged and outspoken about what has happened to Michael Johnson is a freaking travesty. I actually saw people on my Facebook feed say, I have to sign off, that they had to sign off because of all the pictures that had happened to Cecil the lion.
Yes.
And I respect, I don't know. I think I responded with something kind of snarky like, but do we have to say that black lions' lives matter too? Like, what's the issue here? And so I think that our overrepresentation in all of the things, just all of them, has to be addressed, and they show up in our sector. So HIV criminalization matters. It matters. I don't even have much more to say about that.
Yeah. So before you have to run out, and we have to close out in a few minutes, this one isn't as, it's a little bit more of the pithy question, but we've been engaged in this conversation. We've learned a lot more. Some of it was obviously presented by our CDC and HRSA and NIH partners earlier today. There's a lot of new science that has come since the strategy was first adopted in 2010. There's, even as recent as last week in Vancouver, we have even more data about people who are needing to get tested and identified with HIV early and starting treatment as soon as possible, regardless of CD4 counts. We now know that PrEP works, and it works in a lot of different ways and in different populations even, and that the women's question isn't as depressing as it had been for a few years. So let's talk about the role of science itself and its relationship to the work that you do, and whether it's in the prevention or in the treatment and the care and in the social change work that's also connected to that. Particularly around issues of treatment as prevention, PrEP, non-occupational PEP, perinatal transmission, and anything else that you have identified as the science that helps now advance your work, especially in light of the indicators and the new strategy. Michael, you want to start with that one?
Sure. We've done quite a bit of work in pre-exposure prophylaxis in Miami with what's called the DEMO project. And although we know that uptake is generally good, people want to take it, we also know that there are populations that once they start, they don't do it.
Right.
And we also know that certain populations have not been included as too high enough levels in these studies. I would say the black population is a good example of that, and it's been always brought up as a criticism. Now, one might ask why that is, and the answer is we don't know just yet. It's not as if we're not asking for their participation. So there's a lot of work that needs to be done. It's really nice to be able to have this PrEP in here, but getting people to take it in a consistent manner, getting the medications. It's really nice to think that people are going to be able to get these medications, but these assistance programs don't go on forever. Knowing which groups are the best groups to do it is a challenge. And, you know, I'm hopeful, but not as optimistic as people might think today about the injectables. When I look at the data in certain systems, it seems good, but a lot of data seems good in other systems, but they may have challenges. So when are we going to get the injectables? I don't know. Will that make a difference? Well, if people come back for their shots, it might. So pre-exposure prophylaxis is important, but there are a lot of issues involving it. In terms of NPEP, non-occupational post-exposure prophylaxis, you know, I've read a lot of literature on that. And you mentioned some of the data. We talk about reservoirs and clearing reservoirs in HIV and our ability to cure HIV. I mean, that's the big thing. And in Miami, we have a whole cure campaign going on. So you need to get these reservoirs out. You know, one might question whether the guidelines, which are kind of old, really are the right guidelines now for PEP. Maybe 72 hours should be longer. I mean, there's good scientific reason to actually say that. And especially if somebody's infected, you certainly want to start them early according to the reservoir. So I think there's a lot of work that still needs to be done. These are hard questions because you need large populations. You can't do this in 100 people. You can hardly do this in 1,000. We're talking tens of thousands of individuals before you get the data that you need. So yeah, prevention is great. We all want these things to happen, but providers don't really fully understand PrEP or NPEP. They're afraid of it. They're afraid of resistance. They're afraid of toxicities. And nobody's mentioned toxicities. I mean, as a physician, we worry about that, and we worry about everybody who's taking HIV medications, what's going to happen down the road. So there's a lot of great things going on, but there's sure a lot of science left.
Well, Michael, thank you for taking the limitations conversation to the next level, truly. And that also gives us an indication of where community engagement is even more critical for us in terms of not only just understanding the science, but implementing it to the optimal outcomes that we hope in order to achieve the strategy. Monique, did you want to give some thought about that? Because there's just been a little bit of work done in the transformative work.
Well, yes, but I had a story. On my flight down from Washington yesterday. I had an interesting conversation with a young man who was in the jump seat, right? So he worked for another airline and was on his way to work. And he heard me having a phone call before the plane took off and heard me say the word AIDS, right? And he was intrigued by that and ended up having a conversation about it. Young black gay man, had heard of PrEP. I mean, he was pretty well educated, you know? But he was afraid to take it. And he talked about PrEP, sort of the stigma around it, as if taking this pill would be giving someone license to do whatever, right? And my response was, I would rather people have access to the medication that they need, because sex feels good and people are going to have sex and they're going to have sex the way they want to have sex, and at least let's give them a tool that'll give them some level of protection, right? Some level of protection. Because I can think of some people in my life who just didn't have it and are now dealing with the consequences of it, right? So I'm appreciating the medical perspective, and I understand how scale, right, is going to be a long and difficult haul, but we have the tool, and people need it.
If I just might say one thing?
Please do, and then we'll come with our last question and close ourselves.
So I would say most of the data suggests that individuals who take PrEP don't have much change in their sexual behavior. It's like the use of condoms. We've heard, this sounds really reminiscent of if you give people condoms, they're going to use them more. It just doesn't work that way.
June?
Yeah, we actually have a PrEP clinic at Open Arms, and we have a PrEP hotline in Mississippi. And we're taking a different approach to it. Now, my medical director, love him dearly, but he's a man. And so he's looking at this from a scientific way of saying, you know, they take it, but the retention was the problem. I said retention is the problem with men all the time. It's nothing different.
Right.
It's like any medication. There's this thing that we want to do in HIV. We want to change. We want to change everyone's ideas about HIV, but then we don't change our ideas about HIV. We still want to say, hey, they should want to take it to make them healthy. They don't want to take their diabetes medication,
Right.
their cholesterol medication. They're men. Women, on the other hand, we take birth control pills all the time.
We take
our
kinds.
medication. So we kind of did a flip on it and decided that if you're targeting men for this, that's great, but you're going to have to include women.
That's right.
For one, women will take medication. We are accustomed to it. We started our PAPs and we started going to the doctor at 13. So we're already accustomed to that. Also, just think about it along the lines of the birth control pill. It didn't jump off right away. You know, and
That's
it's
right.
the same thing. Give it some time. I am the person who built the clinic and said, if I build it, they will come.
Right.
That's a fallacy. Just because you have it doesn't mean people are going to want it.
Right.
It took 3 years to get that clinic up and going and some life into it. And PrEP and PEP, it will make its way into the mainstream, but it's just going to take time.
Yeah, I think what you're pointing to is also that, as we heard earlier, that it is about individual lives and individual choice, and people need as many options as they can. We don't just have the pill. We have a lot of different ways to get to contraception, and I think that we're looking at the same process for that.
The right tool at the right time.
The right tool at the
For
right time
person.
for the right person and how they identify the risk. So I really want to thank all three of you for doing the best that you could in the 30-something minutes that we had, and to appreciate your work and your thoughtfulness to participating on this panel. And I look forward to all that we all are doing to get ourselves to the end of HIV, even if it's just in the milestones we need to get through the strategy through 2020. So thank you all, and thank you to ONAP for the opportunity. Thank you very much. Give him a big hand, people, a big hand.